Okay, this talk, specific pathologic disorders, is not going to be fully engrossing. It's going to be sort of an overview of things that go wrong. But this is now getting into the meat and potatoes of the spine. So, we talked about facet injuries. So, facet injuries and degeneration. The facet is the doorstop. The vertebra above cannot slide forward on the vertebra below unless something happens here. You can wear it out, you can break it off, but it will slide forward only if the facet is incompetent. And the disc, what happens to the disc with that kind of motion? Shear. It's lousy for the disc. The disc doesn't like it, it will start to tear. Facets prevent the shear stress. L4-5 has less shear resistance than 5-1 because 5-1 has a transverse alar ligament. So 5 doesn't slip as much when the facet wears out. Women have greater sagittal facet angles, meaning less bony wear will allow a greater slip. So 1 in 3 women over the age of 50, 1 in 5 men over the age of 50 get this condition, which is called a degenerative spondylolisthesis. Okay. So, the mechanics. The facet fails. The facet allows the slip due to the facet failure. Do you see the back of that vertebra versus the back of that one? That creates central canal compromise. Patients with this very commonly get central canal stenosis. And then you can get stenosis also from the lateral recess, ganglion cysts, and collapse of foramen. We'll go through all of these. So, the canal changes. Isthmic, okay, there are actually 5 different types of slip. The most common ones you'll see are the worn joint or the degenerative and the broken joint or the isthmic. But people can get dysplastic spondylolisthesis where the bones are just about to fracture and then heal and fracture and heal, fracture and heal. So the entire thing is still intact, but it's elongated. That'll allow the same kind of condition. So degenerative spondy, there's a difference between degenerative and isthmic spondies. Is that a degenerative spondy narrows the canal and an isthmic spondy makes the canal bigger. So are you going to see in general central stenosis with an isthmic spondy? No. What's the term for the patients that have the pain in their buttocks and thighs from stenosis when they walk and they have to bend forward? Huh? Neurogenic claudication. So if you have leg pain only on one side, it's not neurogenic claudication, it's radiculopathy. Okay, we'll continue. All spondylolistheses, degenerative, dysplastic, isthmic, narrow the foramen. Each can have a herniated disc associated with it. Okay, now here's the question you have to start thinking. There is one that has a prominent L5 spinous process and one that doesn't. Can you figure that out mechanically? So what do you have to have an L5 prominent spinous process? You have to have a slip, right? Which one generally has the biggest slip and the most maintained L5 prominent? We do this to our new students all the time. Isthmic spondy, where L5 is broken off, so the L5 vertebra slides forward, but the L5's process is broken off and still stuck to the sacrum, so L4 goes forward. That's the one that's most prominent. So, symptoms. Slip can present with a flat back syndrome, right? As this goes forward, you lose your disc height. Theoretically, you can have a problem with flat back. You can have lower back pain. Look at the disc. Look at the beautiful discs below and above. These discs look great. Look how crappy that disc looks, right? Do you see the sclerosis of the bone? Sclerosis is due to something called Wolff's Law. Wolff's Law says that bone under stress lays down more bone. So areas that are under great physical stress will have increased bone signal. Lower back pain is quite common. They can have instability. So instability is the shift of the vertebra in certain positions. So commonly somebody's sitting in a chair for an hour and they try and get up and they walk their way up, right? What are they doing? They're trying to prevent the shear force by using their arms to transmit the weight from their torso to their legs. So people like this will have shear forces. Neurogenic claudication. Again, we talked about that. What is that again? See, I got to keep you guys on your toes. So it is buttocks and leg pain that occurs with standing and walking that is relieved by sitting and bending forward. When they go to the supermarket, what do they look for? Shopping carts, right? Because what are you doing? Your weight's on the front, you're bent forward, your canal's open. You can walk all day long with a shopping cart. So we call it the positive shopping cart sign. So lateral recess stenosis. Here's the spinal canal, and we haven't really gone through the anatomic changes that occur. We have a whole lecture on that. But this is here's the left lateral recess, it's nice and open, and the right one that's closed down by this thing, a ganglion cyst. So, what the heck is a ganglion cyst? Is that a cancer sitting in the spine? No. Very simply, when you have a degeneration of the facet is lined with a cell-thin layer of material called the synovium. Synovium creates synovial fluid, right? So if you tear the capsule of the facet and this thin layer of material bulges out, creates a little herniation, what's it going to do? Doesn't know any better. It's going to make more fluid. This is how you get one of these cysts. This cyst grows right out of the facet. You can see this facet is degenerative but doesn't look as bad. The white signal here and that facet cyst, that's a synovial cyst. You can see the same thing right down here. Very common in the spine. You can get lateral recess stenosis from bone spurs, which is an enthesopathy, right? Okay. So this isn't a facet cyst, that's a bone spur, and that's the lateral recess. So what happens when this guy stands up? Buttocks and leg pain. When he bends forward, he feels better. Leans over to the right side, worse. Leans to the left, feels better. You can almost make your diagnosis just by watching him come into the office. Here's another facet cyst right here. Lateral recess stenosis is associated with a degenerative slip, but can exist independently. This is a case, look at how big this, everybody's seen people with arthritic fingers, right? What happens? They get these big bulbous joints. So a normal joint that degenerates becomes enthesopic. You get more bone situation. Same thing happens in the facets. Facet gets larger as it gets more arthritic. You don't have to have a slip, but you can have lateral recess stenosis. There's no slip here. And extension narrows the lateral recess, and flexion opens it up. Again, we're going to keep harping on bending forward versus bending backward, a huge and wonderful diagnostic tool to figure out what's going on. Central stenosis, the same thing. You have the disc bulge, you have the enthesopathy or the bone spurs, and you have ligamentum flavum hypertrophy. That's a one problem, especially men get. We have less hair on our heads and more ligamentum flavum in our spine, which is a bad thing either way. And that's what happens. So, this is again a CT myelogram of stenosis. You can see the dye in the canal. You can see that the disc doesn't look like it's pushing in. Where is the push coming from? What is that? That's ligamentum flavum. This is ligamentum flavum hypertrophy. You can see the same ligamentum flavum not causing stenosis there or there, but it hypertrophied at 4 or 5, and look what happened to the canal. All of this black area here, that's space taken up by ligamentum flavum. Dr. Evans and I talked about developing Flavoy. If we could do that, we would be walking in Sweden with the gold medal around our neck too. But unfortunately, everything that dissolves ligamentum flavum dissolves nerves, so it doesn't work too well.
What causes the hypertrophy?
Age. Well, also disc height loss as the ligament will buckle in, but age allows these things to get larger. Why? I can't answer that question either. So, isthmic spondylolisthesis with late changes. This is hard to see. See how the rest of the vertebra line up nicely? See how this one doesn't line up with the edge of the sacrum? That's a 50% slip. So when you have slips like this, most of them don't go beyond a grade 1. If you take the sacrum and make it into 4 segments, 25, 50, 75, and 100, anything from 0 to 25 is a grade 1, 25 to 50 is a grade 2, et cetera, et cetera. This is a grade 2 to 3. Most slips don't get bigger than a grade 1, but the greater the slip, the greater the chance for symptoms. Think about, here's the foramen. You can see the nice foramen here. Where's that foramen there? And what's the first thing this guy comes? Oh, I've had back pain my whole life. I've dealt with it. It's been okay. But now my leg, I can't stand up. I need to bend forward. I feel much better with a shopping cart at the supermarket. I like to ride my bicycle, but I don't like to get off of it. I like to ski because I'm bent forward, but I hate standing in the lift lines. All makes sense? It's because just think of the positioning when you think of the spine. So, spondylolisthesis with a slip. This is late. So see the pars here? See the pars here? See the break there? See the slip already? So the fracture has gap. This is a late diagnosis. This guy has had a spondy for years. What do you think the general incidence of spondies in the general population is? Asymptomatic or symptomatic? It's 6% in general. In athletes with back pain, it's 15 to 20%. In Eskimos, what's the percentage? 50%. So we know there's a genetic component to this. Inuits, I'm supposed to say, I think. That's okay. I'm inappropriate. So what happens is your fracture has gapped. The fracture ends are atrophic. Do you see there's no growth in here? It's sort of empty. There's plastic deformation of the disc, right? The disc has now, it still has good disc height, but it's starting to slip forward because of shear. And this is one that's a little too late to go ahead and repair a defect. Here's a stress reaction. We see a lot of kids. In fact, we're probably the #1 place to see these injuries. They haven't written about them much, but this is a kid who comes in. He's a skier, he's racing, and he has terrible back pain, especially when he loads his left-hand turn. And what is he doing? Look at the pars here compared to the pars here, here, and here. See how it's highlighted? See that little line there? This is a pars fracture. This is, well, I say prior to fracture. It's right at the edge of being fractured. This is how it occurs. And this is what it looks like. So this should be one solid sheet of bone here and here. And if you look carefully, you can see the fracture line starting to develop here. This one's fully completed. This kid, if you catch him early enough, we have a chance of healing him. If we catch it when the first fracture line appears, a good percentage of them can heal. We don't have statistics yet. We're still working on those papers. But this is one, the pars fracture with displacement. So you look at the MRI, and you look at the pars here, and you see the breakdown there. The back of that facet is behind that. This is already displaced. This one is one that's a real problem child, what we'll talk about later. So you can have a pars atrophy. So this is a fracture where he hasn't slipped yet. The alignment's still good, but it's atrophic. This piece belongs attached there. And there's very little in between. This doesn't want to heal. This one, unfortunately, is probably not the best candidate to try and repair. Again, we'll talk about that later. So herniated discs. Yes?
Is there an average age in these children that
8 to 15.
when they actually fracture?
8 to 15. I've seen them as early as 6. That's pretty rare. And I've seen them later, but they probably have fractured before then, but haven't slipped at that point. So, they come in at 21 years of age. They're probably, you can have a traumatic injury, but I've only seen 2 in my career. So it's very rare to have that.
So they're usually microtraumatic, repetitive?
Yeah, they're repetitive stress injuries.
Yeah. Is it extension loading or what?
Extension, yeah. skiers, volleyball players, wrestlers, football players, gymnastics. Yeah, extension activities cause it. Again, we have a whole section on this. So, here is your herniated disc, and the patient has leg pain. Would you expect that? Do this. Yeah, all normal. So, this herniated disc, which is the jelly from the inside of the disc, commonly occurs in about 1% of the population. So 1% of the population only tears through all 30 layers of the annulus. And then you end up with the nucleus coming out. I like to tell my patients, it's like taking the cap off a toothpaste tube and squeezing the tube. And it's going to come out, and it's going to come out right at the hole that you just created by popping the disc. Interestingly enough, in these patients, many of them will have back pain for months to years. And they bend forward and they feel a pop in their back and they're jolted, but their back pain is gone. And for a day and a half, they are thrilled until the inflammation of the nerve root comes on, and then their leg is on fire. And so this is a common scenario. Be very wary if somebody comes into your office and says, I got a pop in my back and now I feel great. You know, in 2 days, if they're not complaining of leg pain, they won the lotto, but most of them are going to have a disc herniation. Now, the disc herniation, depending on the location, will depend upon the nerve root that's being affected. So you can have anywhere in the lumbar spine, right, from L1 through S1. Is a disc herniation going to affect S2? You can nod your head like this. Yes, because S2, remember, travels down the center of the canal. That's part of the nervi irrigantes for Cauda-Equina syndrome. But you have to have a massive herniation to cause that. So, there are two nerve roots at any disc level that can be affected. There is the exiting nerve root right here and the traversing nerve root right here. 95% of disc herniations occur right there and are going to affect the traversing root, and about 5% of disc herniations occur here and are going to affect the exiting nerve root. So an L4-5, here's a question on the test that you're going to have to answer. An L4-5 root, L4-5 herniation can affect what root? And if you say L5, you get it right 95% of the time, but you lose 5% of the time. So you have to look for what you're looking for. An L4-3-4 herniation will affect the L4 nerve root, but if you have a herniation here or a herniation here, you're going to have the same symptoms. In fact, the exam is going to look exactly the same. So you have to be very cautious about trying to figure out where these things are coming from. And another thing is an extruded herniation that fills up this whole area can cause central or lateral recess stenosis. So a patient who has never had neurogenic claudication and comes in and says, I can't stand up, my legs, my buttocks are on fire, but I bend forward, I'm great, doesn't have to have central stenosis from a slip, can have it from a herniation. And in fact, the history is such that it's probably a herniation because back popped and now I've got it 2 days later. So listen to your history. So herniations causing I even talk about it. So here's a guy who had a myelogram, and you can see he's got bulges at each level, but he's got a herniation causing central compression. What does he have here? Flat back. Flat back from antalgia, because this guy doesn't want to stand up because he's crushing his nerve roots. He's staying bent forward because it feels better. And antalgia, again, can cause a list. So if somebody comes into my office, I'm okay, my leg's a little painful, but I'm okay, and you look at them and they're way off. They have a list, an antalgic list. Interestingly enough, if you did a microdiscectomy on them, that list would stay around for 2 to 3 months. And they have to correct it by looking in the mirror. That's one of those things I can't answer why. So, the femoral nerve can create problems. Femoral nerves can mimic a hip disorder because, right, it radiates into the front of the lateral aspect of the thigh, as well as the buttocks. The buttocks is the garbage pail for spine referral pain. Any route from L1 through S1 will refer into the SI joint, and so you've got to be very critical when you're making a diagnosis. But L2 through 4 will have pain in the front of the thigh. These people are interesting because they can't take a step forward, because as they do, what are they stretching? They're stretching their hip, right? They're doing a femoral stretch test. So they're going to walk with a limp because they don't want to stretch their hip. Find out where their pain is. You can see as you bend forward, you stretch the femoral nerve, which connects down to the knee. Eli's test is another test that's the same as a femoral nerve test. You stretch the femoral nerve. It's an SLR, straight leg raise test, for the femoral nerve, not for the sciatic nerve. Foraminal collapse, very common, very commonly missed. It can occur with an angulatory change of greater than 5 degrees to a vertebra. Chronic angular change causes what? Enthesopathy, or we have bone spurs. What's living out in that area right there? The exiting nerve root. It acts just like a far lateral disc herniation. So you have an angulation which closes down the foramen, and then you have a bone spur to make it even worse, and they stand up and they get leg pain. But it feels better when they bend forward. So this is what it looks like. So you can see an angular collapse here. That's about a 12-degree angular collapse. So if this person came in with left leg pain, standing and walking, and it looked like an L, what nerve is that? This is 5, 4, 3. I fill in the blanks for you guys, making it easy. That's an L3 nerve root. So they come in, where's L3 dermatome, right? Anterior thigh. So they come in with anterior thigh pain, and I look at this x-ray. I don't necessarily need an MRI. I can look at that and go, whoops. I can look at that and go, that's probably where it is. If he comes in with left leg pain that radiates to the ankle but not below the foot, right-sided pain, look at the femoral collapse and angular change here. So you can just look at x-rays and you can start to figure things out even without an MRI, and this is why x-rays are so valuable. It drives me a little crazy nowadays that x-rays are sort of not used as much as MRIs, because x-rays are almost a better tool than an MRI for certain things. We've talked about this. Everybody knows what that is, right? You remember the differential? Flat back syndrome is one, but it can be antalgia, altered mechanics. They posteriorly rotate their pelvis to reduce the lumbar lordosis. It could be from stenosis, flat back, hip flexure contracture, or knee contracture. So people walk in and look at that. You already have a parameter that you're looking for. That's how you make a differential diagnosis. And again, this poor gal, I pick on her all the time, but this is what happens. They straighten their knees, their back bends forward. If you look at their stance, they're flexed forward, they're bent kneed. Pretty easy to pick up. So hyperlordosis, as we talked about earlier, it's either an anterior pelvic tilt. So what will cause an anterior pelvic tilt? Contraction of the hip flexors, psoas or hip capsule or something. So that can cause a hyperlordosis. Or they have to accommodate a hyperkyphosis of the thoracic spine. This happens, if you look carefully, you'll see that there's a bigger kyphosis here already. This patient has probably a 75-degree hyperkyphosis causing a hyperlordosis. This is what it looks like. So you have a hyperkyphosis in the thoracic spine, and if you don't want to walk with your head in front of your pelvis, so you're going to bend your knees to try and straighten that out. The expense is quadriceps femoris, chronic contracture due to bent knee stance. You can't walk all day long like this because your quad muscles won't take it, and so you're going to have less walking ability. This is what a kyphosis looks like. If you use your eyeballs and just look at these things, they show up easily, caused by Schurman's, postural kyphosis, or osteoporotic kyphosis. We'll talk about how to diagnose all these. And this is what happens. You extend your lumbar spine to compensate for this. You can't extend enough. You bring your pelvis back by bending your knees. You can have osteopenic kyphosis from height loss of the vertebral body. We've seen that picture before, and this is because of osteoporosis. Scheuermann's disorder. Scheuermann's disorder is an end plate disorder that we'll talk about more thoroughly, but this occurs in younger kids that have soft bones. You already have a normal kyphosis of your thoracic spine. If your bones are soft, you're going to load it too much and create a continuous bend, and that creates this curve. This is 72-degree curve. What's normal? 20 to 40. Good, you got to remember these things. Okay, oh, poor gal, I pick on her so much. Okay, annular tears. We'll talk about these in young patients, but they can occur at any age. Acute lower back pain, normally from a load and rotational injury. Remember the magic letters? BLT, good. Symptoms tend to be worse with flexion and relieved by extension. Why? Because you load the disc in flexion and you unload the disc by loading the facets in extension. Okay. New annular tears. This is a new one right here. There's still a little signal in the disc. Normally only a portion of the 30 annular layers are affected, and the outer posterior annular fiber is typically torn initially. It normally goes from outside in. Doesn't have to, but it can. And of course, you can have a herniation if all the annular fibers fail. And again, this is what it looks like, a full tear. This guy is ready to have a herniation with the wrong move, and this is a lab-induced tear in a normal disc. So, we are again going to talk about annular pain. Nucleus pulposus is highly noxious to tissue, right? Arachidonic acid, metalloproteases, all these other wonderful things. The posterior third of the annulus and the PLL are highly innervated by nociceptors. Another bad thing. The posterior annular tear allows apposition of the nucleus, that caustic, miserable nucleus, to the nociceptors, causing sensitization, and tears through the annulus to the exterior allows neovascularization and nociceptor growth. So unfortunately, we're designed to have back pain. That's a problem, which is why Dr. Evans and I are so busy, unfortunately. Again, a normal disc, you can see the nucleus here, you can see the annulus here, and then a tear through the nucleus, through the annulus. So what happens over years and years of these degenerative changes? The disc can erode away, literally disappear. So look at the heights of these normal discs, look at that disc right there. Do you see the extra white? What is that from? Wolff's Law. So this disc is undergoing a lot more stress, and it's creating more bone deposition because the impact is not cushioned by the disc anymore. So that's a typical finding for something called isolated disc resorption. The disc literally erodes away. In fact, we'll see other images where you'll see a vacuum phenomenon. You see all of this here? That's gas in the colon. I call them infarts, but that's another story. Sorry. But you'll see gas in the disc space because if there's no nucleus left and you extend backward, you create a vacuum. Vacuum of pores, you're going to pull carbon dioxide, nitrogen gas out of the tissues into the disc. When they bend forward, it'll go away. That's an indication there's nothing left. And it leads to this condition on the MRI, IDR-Isolated disc resorption. These are normal discs above, and this, do you see the swelling of the trabecular bone here and here? You see the end plate fractures that occur? This is an incompetent disc. These people are miserable if they have back pain. I can see this exact same MRI and a patient have no pain whatsoever, no pain. And the difference is how they're wired, as we talked about earlier. So there are modic type 1 and 2 changes, and we'll go over this again on the MRI talk. But modic 1, water is white, so we're looking at a T2 image, so we see the CSF, which is water, is white. So that vertebra is inflamed. This is an incompetent vertebra. If it goes old and stays there for years and the patients get over it, those inflammatory changes will turn into fat. So you notice here the water is black, and fat is white. Here, water is white, fat is black. So that's water or inflammation, that's fat. But the same end plate changes. This person was able to get over their back pain, doesn't load it as much, but this is modic 2. So myelopathy. Myelopathy is something where this is a lumbar spine course, but because you're going to see it in your office or you're going to have patients tell you symptoms that don't fit, you got to know about it. They'll complain of incoordination of the hands and incoordination of balance. They'll have some, not everybody, will have unusual paresthesias in a non-dermatomal distribution. You know, my left foot's a little numb, my right knee's a little numb, my hands are a little numb. Lermit's sign. So Lermit's sign is an actual contusion to the cord. You bend your head a certain way and you get lightning type pain down the spine into the arms or into the legs. That's points off if you do that, and make sure you do the appropriate exam because they may have compression of the cord. And they have weakness that doesn't fit with normal myotomal patterns. So they may have a C, here's, let's see, 2, 3, 4, 4, 5, 5, 6. They may have a C6 radiculopathy. They may have biceps weakness. They may have some MCP extensor weakness, but they will also have strange weaknesses they can't describe. My hand, I can't grip well. I feel off. Things are disconnected, so look for this kind of problem. DISH, diffuse idiopathic skeletal hyperostosis. Look at the amount of spurs here. Are these typical enthesopathy spurs? No. DISH occurs in patients, 10% of diabetics and 2% of the normal population. Why it occurs, we don't know. The interesting thing is, do these patients have back pain? Generally not. Their back is stiff. Stiffening of the vertebra, lack of motion makes back pain go away. Now, this guy doesn't have DISH down here. Might he have pain at 4, 5, and 5, 1? That's a possibility, but I can assure you he has no pain up here. And then arachnoiditis. We talked about this a little earlier with the pantopaque myelogram. We used to see this all the time. You're injecting an oily substance in the spinal canal. Can't be good. Wasn't. So what it did is it created arachnoiditis. So what is the arachnoid membrane? There's 3 layers of the nerve membrane. There's the dura, the pia, and the arachnoid. And it has many filamentous sections. When you pull the arachnoid away, you can see these little connections between nerve roots. And so the Latins, being smart as they are, called it a spider's web, which is, of course, an arachnoid. So it's the arachnoid membrane. Think of the arachnoid membrane as a negatively charged membrane. So negatively charged particles repel each other, right? So when you look at a normal spinal canal, the nerves are not stuck together. They repel each other. You can look at them individually. Think of arachnoiditis as somebody smearing positive charges on some of the membrane, and the nerves start to stick together. The membrane charge is lost. It creates root clumping, preventing CSF contact. But the interesting thing about arachnoiditis is it can be totally asymptomatic. I can see somebody come into the office. This is pretty obvious. This is clumped badly. They have no symptoms. The next person has miserable right leg pain. The next person has mild buttocks pain. The next person may have bowel and bladder issues. So arachnoiditis is unpredictable, but you have to look for it. So hip, pincer, and cam mechanisms. This is my partner, Dr. Philippon's strengths and my weakness, because this actually was developed after I got out of residency and fellowship, so I can give you a slight information on it, but I can't tell you enough about it. Dr. Evans maybe will speak on it. Throw him under the bus. So, the 2 mechanisms, this is a normal hip where you have plenty of room for the hip ball. Here is a pincer mechanism where the front of the acetabulum is thickened up. And here's something similar, but it's the ball, the head of the ball has a bump on it, or both cam and pincer at the same time. And these can create pain because you can tear the labrum. Labral tears cause hip pain, but hips can refer into the lateral aspect, can refer into the buttocks, and rarely but occasionally can refer into the SI joint. So you have to be very cautious, and there are exams you can look for. Some people talk about the C sign. People come in and grab their hip and grab it with a C. They have pain when they cross their legs, getting in and out of a car, getting off a bicycle, getting up and down stairs. So you have to differentiate this from other things. Hamstring apophysitis. I call it tennis elbow of the butt, which is really what it is. So if you look at the hamstring insertion, do you see how ragged it looks? You see some free bony pieces here? That thing has been pulling on and off forever, and it looks, when patients come in, it looks similar to a straight leg raise test when you lift up their leg because you're pulling on their hamstring. The difference is they'll be exquisitely tender in their hamstring, and they won't have any neurologic findings. Sacroiliac joint. Sacroiliac joints, again, we talked about a diarthroidal joint with syndesmosis. Motion significantly greater in young adults, lose motion with age. Innervation from the lumbosacral roots, which will be important later when we talk about sacroiliac joint treatment. Pain radiation in non-sacroiliac joint patients causes pain from the PSIS to the posterior thigh. Most common region initially affected by spondyloarthropathies. We're going to talk about inflammatory changes. The sacroiliac joint is famous for being the first part of an inflammatory problem. You can't forget metastases. A normal MRI looks like this. You can see holes in the bone here, here, here. This is metastatic disease. Even though it's rare, you have to be aware of it. You have to look for it. Metastatic disease, this is interesting because this looks like a guy who came in and he had a prior fusion seen elsewhere. It didn't work, but look at the bone. He's got holes in the bone all over the place. This is metastatic disease. He had a problem in his spine, but his spine problem wasn't the thing that's going to hurt him. It's the metastatic disease. Look at the pelvis on the right. Look at the pelvis on the left. Big difference? Say yes, because that is involved with a sarcoma involving the hemipelvis. So again, these things are rare. We probably diagnose 1 or 2 a year, but we see them and you have to be aware of them. Conus Syringomyelia. So I had to bring this up because this is the only one I've ever seen. This is just the base of the conus and it's got a big cyst in it. And it causes sometimes lower back pain. I also had a little lower extremity foot symptoms in the beginning of bowel and bladder. Why? Because the conus is S2, 3, and 4. Keeps you off the floor. Okay. And intrathecal tumors. Again, these are very rare. I had to pull out a lot of MRIs and x-rays. So there's a little intrathecal tumor here and a little one here. This one was asymptomatic. This one I had to send to a friendly neurosurgeon to take care of. Okay, what time is it?